I'm Alice Park, and I'm so happy to be joined today by Dr. Leana Wen and Dr. Scott Gottlieb. Dr. Wen is an emergency physician and visiting professor at George Washington University Milken School of Public Health. She is also former health commissioner for the city of Baltimore. Dr. Scott Gottlieb is resident fellow at the American Enterprise Institute and led the Food and Drug Administration from 2017 to 2019. Welcome, both of you, to this Time 100 Talks.
Thanks.
Thank you.
I'd like to ask both of you, as you observe this pandemic unfold and watch the political and public health responses, Dr. Wen, let's start with you. Does a part of you wish that you were still health commissioner in Baltimore?
Yes, I'm an emergency physician and I'm trained to be on the front lines. I still practice clinical medicine, and so I'm glad to be on the front lines in that respect. But this is what all of us who are public health experts have trained to do, really all of our lives, all of our professional lives at least. And I think all of us in this time are trying to do our part. I see my colleagues who are the local health officials, state health officials doing their best to serve the residents and protect their health and well-being all across the country. And I wish I could join them there, although I think I and Dr. Gottlieb and others are also doing our part to be public health communicators, to do research and policy analysis, and really just to contribute our part at this time that we're really in this all together.
Yeah, look,
Gottlieb, thank you. Do you wish you were still there at the FDA?
Same sentiments. I mean, obviously, I wish I was there. I mean, spent a lot of time working on pandemic preparedness in the years leading up to this. Back in '03 and '05, when I was at FDA, and we were worried about a pandemic flu at that point, worried about a bird flu. But certainly wish I was back at FDA with my colleagues to help lead the agency through this.
And since both of you have served in public office, I'd like to get your perspective on the push and pull between politics and public health that we're seeing played out in the country today. Does that concern you? And is this kind of tension inevitable, or is it avoidable? Dr. Wen, let's start with you.
Public health hinges on public trust. I am very concerned about what we're seeing with the politicization of health and medicine. So many of the things that we ask people to do at times of public health crises relies on that public trust. If we're asking people to change their behavior fundamentally, to do things like sheltering in place and not go to work, not see their friends for prolonged periods of time, or we're asking people for their contacts and everywhere that they've been and to go get tested and to be isolated for a period of time. I mean, all of these are quite extraordinary measures. And it does depend on the public's trust in government institutions, public trust in science and medicine. And I do fear that so much of the rhetoric now somehow pits public health against the economy, or pits public health against some other entity, politics, or some partisan goal. And I really worry about what that means, because ultimately it ends up compromising people's health. When we don't follow the science, we pay the price.
Well, look, I think the public health issues can transcend politics if public health leaders are doing a good job trying to explain the goals to policymakers and also explain the goals of what we're doing to the public. Where I worry about it is things like, you look at contact tracing, for example. There's a lot of discussion about contact tracing and whether that constitutes the government being too intrusive into people's lives. If we don't get to effective case-based interventions and get to a place where we can do very effective contact tracing in the fall, it's going to be very hard to contain this virus and prevent outbreaks and epidemics in the fall. And that's gotten sort of mixed up into a policy context and sort of a policy debate about what the proper role of government it is and whether or not that's too expansive of a role for government. And that's where I start to get concerned that some of these sort of basic public health interventions and public health considerations are getting swept up into a policy debate or a political context. And I think that can be you can transcend that if you're communicating effectively, if you're talking to the public effectively about what things are and are not, what the goals are, and that's the job of public health leaders in these roles during this time of crisis.
And Dr. Gottlieb, you just mentioned, how looking toward the fall and what that will look like. We're now in the midst of reopening with every state already opening different parts of various businesses. You submitted a letter to Congress that outlines a plan for this, and you had some interesting proposals that really focused a lot on needing to drill down and starting to appeal to people on a more individual level, so that they're motivated to do the right thing. You had some interesting ideas about, for example, making sure we had hotels or other types of accommodations for helping people to self-isolate, maybe even having some monetary incentives there for isolation. Can you talk a little bit about whether you're seeing any of these ideas being picked up by communities and what it would take to implement them?
You're seeing them picked up at a state level. I mean, what I worry about in the fall is that we have very pervasive screening that's widely available to people, and particularly available in communities and at places of employment that are at risk, at greater risk of COVID. Not everyone is at equal risk of this infection. Not everyone faces the same risk of contracting this infection. There's certain communities that face more risk. There's certain people, because of where they work or how they get to work or where they live, that face more risk. And we need to make sure we get screening into those communities. And we need to make sure that we're screening not just for symptomatic disease, but also offering it to people who might be asymptomatic or even mildly symptomatic. And that that getting COVID, having a diagnosis, doesn't become something that's punitive. It isn't something where you're forced to lose 2 weeks of wages, and maybe you're looked at negatively at a place of employment or in your community because you might have put other people at risk. If this is something that people perceive as punitive, having a COVID diagnosis in some way, people are going to be discouraged from getting tested, and we need to make sure that doesn't happen. And that's why we talked about in that letter that I sent with Dr. Wen was on it as well, but a number of public health leaders talked about things like trying to provide for lost wages, trying to even provide a stipend for people who agree to self-isolate, trying to make sure that people have a place to safely self-isolate. So if you can't self-isolate at home because you live in a crowded housing situation, you have other family members that you don't want to put at risk, that the state provides for a safe location. And that's where we talked about a hotel room, so you can self-isolate for the period of time in which you're contagious. I think that we need to try to put these measures in place and encourage people to get tested, encourage people to self-identify if they think they might have signs or symptoms of COVID.
Dr. Wen, would love your perspective as former, health commissioner in the city of Baltimore. How do we address what Dr. Gottlieb referred to, which is that we're beginning to see from the science that there are communities who are disproportionately affected by COVID-19? What do we understand about some of the biological reasons, as well as perhaps some of the social and cultural reasons for that?
Yeah, so I think there are two major points here about the communities that are disproportionately affected. One is the understanding that for actually for many people, for all of us, social distancing is a privilege that not everyone has. There are essential workers who, until now, may not have been thought about as essential. We do think about essential workers as healthcare workers, as the doctors and nurses, but we're also talking about the grocery clerks, the cashiers, the bus drivers, the people who deliver our packages. These are individuals who many of them are barely making a living wage, but have had to go to work during these times. And of course, they tend to come from communities that have disproportionate effects of COVID-19. Also, these are individuals who may live in crowded housing, as Dr. Gottlieb was saying, may not have the option of social distancing at home, may live in multi-generational housing where one person is an essential worker, and even if everybody else is sheltering in place, that person could still bring back the virus and infect everybody else too. So there's that element of how not everyone can choose to do social distancing. And then on top of that, we know that there are communities like Baltimore that already suffer from disproportionate effects that in medicine we call acute on chronic, that there are chronic underlying health disparities. In our city, there are communities just a few miles apart that have a 20-year difference in life expectancy. And of course, that difference in life expectancy, a neighborhood living where somebody born today can expect to live 65 years versus 85 years, these are also communities that face the disproportionate effect of other healthcare problems like high blood pressure, like chronic heart disease, like diabetes, which are then predisposing to having the severe impacts of COVID-19. So in essence, you have the double whammy. You've got the fact that people in communities like ours are the essential workers who can't socially distance, combined, as you were saying, Alice, with the fact that they already suffer from disproportionate effects of health disparities. And so I think COVID-19 has unmasked many of the structural inequities. We have to address this acutely by providing for testing, healthcare, isolation, exactly as Dr. Gottlieb outlined. But longer term, I hope that there will also be a light that's shown on these chronic underlying problems, these systemic racial inequities that have gotten us to where we are too.
And I think this is going to lay a really strong foundation for discussions about if and when we get a vaccine, for example. One of our previous guests on Time 100 Talks was Dr. Ngozi Okonjo-Iweala, who chairs the board for the Global Alliance for Vaccines and Immunizations. And she talked about how we need to think of the COVID-19 vaccine as a global good, as something that's available to anyone in the world who needs one. So if and when we do get a vaccine or vaccines, how do we ensure that they are distributed to everyone on an equitable level and on an equitable basis and to everyone who needs one? Dr. Gottlieb, your thoughts on that?
Well, look, I think first and foremost, we need more than one manufacturer to be successful here because there's no single manufacturer that's going to be able to supply perhaps the United States, let alone the entire world. So you're going to need multiple manufacturers to make it across the finish line here. I think the reality is that you're going to see nations supply the vaccine to themselves before they supply it globally. And this is just a historical fact. If you look back to 2009 with H1N1, there was efforts made by different countries, both the United States as well as other countries, to make sure that they had the vaccine available for their own populations before they made it available globally. We had vaccine that was destined for the United States in two friendly nations that was being manufactured in two nations that we maintained very good relations with. And they didn't make that vaccine available to us until they satisfied their local needs, even though that vaccine had been manufactured for the US. And we had a manufacturing facility here in the US that was manufacturing vaccine intended for the UK. And we didn't let it go so easily. So that you saw that kind of behavior. I would expect that we're going to see some of that this time around as well. Now, that said, the manufacturers that are developing vaccines are starting to manufacture at risk, not tens of millions of doses, but potentially hundreds of millions of doses. And so I think that there's going to be a lot of supply initially, but certainly not enough to fulfill global need. You might not need enough to fulfill a global need initially, because if there is a seasonal component to this virus, if we settle into more of a seasonal pattern, it's only going to be certain nations where you're going to be seeing outbreaks and potentially epidemics heading into the winter or into 2021, depending on when you think you're going to have a vaccine available. So you're probably going to make it available to the nations that are at highest risk of outbreaks at that time, after you probably satisfy your own local needs for the vaccine. In terms of when we're going to have it, I think, as I said, I think these manufacturers are going to be manufacturing tens and hundreds of millions of doses at risk. So we'll probably have vaccine supply available heading into the fall or winter of 2020. I think what we probably won't have is the card turned over on the big pivotal studies that we need to sort of demonstrate safety and efficacy in these settings. I think that we're more likely to have those trials underway probably in the fall. You're going to need a certain prevalence of infection in order to determine whether or not these vaccines are in fact working clinically. We're probably unlikely to have that level of infection in July, August, even September. I think the most likely scenario is we sort of have a quiescent period of time in July and August. We see transmission break off to some degree, and it'll pick back up as we head into the fall and winter season. That there's going to be some level of seasonal component here in the United States and even around the world. And so you're probably not going to be able to enroll those big clinical trials and have enough people, where enough infections spreading in the background to be able to determine the safety and efficacy of these trials really until the fall.
Dr. Wen, I'm just curious about your thoughts. Dr. Gottlieb really pointed out the reality of our, current sort of manufacturing infrastructure. Is there a way to shift those priorities? We do have manufacturing at risk, which means that, there would be a greater incentive to produce these vaccines for the good rather than for profit. Is it time that we need to rethink pandemic vaccines and vaccines in response to emerging infectious diseases differently so that we've got a different infrastructure in place for that? And are we seeing that at all as we sort of get hit by wave after wave of these pandemic outbreaks in recent years?
I think we need to be rethinking our entire approach to emergency preparedness and response. I mean, we are now seeing the effects of decades of neglecting our public health infrastructure. You and I have talked about this in the past, Alice, of how public health has no face until something bad happens. And it's just not a popular topic to talk about prevention because you are preventing something bad from happening. You don't see the impact and the positive effects of that work until something bad actually occurs. And so we need to be looking at the investment that's needed in public health all across the board, local, state public health, as well as our CDC and other infrastructure. I think right now I am really concerned about complacency. I think it's possible, right, as Dr. Gottlieb was saying, that we're going to see potentially a decrease in infection over the summer. I think also as states are lifting their stay-at-home orders and reopening to various degrees. And I'm afraid that we're going to draw the wrong lessons from that. Reopening does not mean that the virus is gone. It does not mean that it's now safe to go out. And especially if we have a decline in cases due to the weather over the summer, I'm afraid that people are going to think, oh, we're through this problem. And not to worry, we have a vaccine on the horizon and treatments on the horizon. So let's not worry about this anymore. And then come the fall, we could have a resurgence that's even greater of COVID-19 combined with influenza in the winter. And we won't be ready once again. And I worry that we are not doing nearly enough to prepare, even in the short term, much less the long term, which of course I agree we need to be investing in that preparedness. But what about preparing our hospitals for a surge in the fall, winter? What about making sure that this time our healthcare workers do not run out of that personal protective equipment as we did last time? What about getting our testing, contact tracing to the right capacity that it needs to be? It's not now. How about let's work on getting it ready as much as we can during the summer and fall months for when this will come back in the fall. I just worry that the American people are not ready for that type of resurgence and potentially for having to re-implement shelter in place and other types of orders again. And last time, if we were not ready, we could say hindsight is 2020. We could have known better, we didn't. This time we have no excuse.
Yeah, the kinds of things we wanted, it's an excellent point. The kinds of things we want to think about doing for the fall are different than the things that we're doing right now. And we need to start preparing for that. In 2009 with H1N1, we did see transmission. It was epidemic all the way into June. And if you look at the graph of that flu, it broke off in July and August and really collapsed and started to pick up at the end of August and into September. And you saw sort of the second wave of H1N1 and it picked up very quickly. This isn't an influenza strain, obviously, but there is going to be some seasonal effect here. And we could see transmission break off in the summer to come back very quickly as we enter the early fall. And we're going to want to make sure that those case-based interventions and screening is in place. One of the things I worry about is that it might be hard to get screened in a community. We're going to have very, very robust screening technology. The problem in the fall won't be on the back end. The problem right now is on the back end. We didn't have enough screening platforms in place. The problem in the fall won't be that we don't have enough screening platforms in place. We will. We're going to have more PCR-based screening. We're going to have a lot of point-of-care systems authorized on the market, antigen-based tests that could do point-of-care screening in the doctor's office. I think the bigger challenge in the fall is going to be on the front end. Where do you go to get screened? And I think there's going to be a lot of locations that can do screening and currently have systems installed for doing screening. The Abbott ID Now, the Sophia 2, all these point-of-care systems that have been authorized to do coronavirus screening that have a big installed base in doctors' offices and pharmacies that could be doing coronavirus screening. And if you call up your provider and you say, I feel like I have the flu, they're not going to say, come in and I'll test you. They'll say, let me give you the location of a site that does special COVID screening. And it's going to make it cumbersome to get screened. And so the opportunity to do very, routine, widespread screening in the community is going to be lost because a lot of locations aren't going to want to test for COVID because of the implications. Because if you turn over a positive COVID case in your doctor's office or in a pharmacy, it's going to mean you have to shut down for the day and do a deep cleaning and maybe quarantine your staff. And so people are going to be reluctant to do that testing at the point of care, point of where the consumer is. And so we could be thinking about how to get in place universal guidelines right now so that doctors can do testing in their offices without having to go through extraordinary steps if there is a positive case in the office. Those are the kinds of things I think we should be thinking about, how to push screening out into the community and not just relegate it to special sites. Because if we do that, if it's sort of drive through screening at special sites, a lot of those communities that we talked about that already face obstacles getting access to testing are going to face even more obstacles getting access to testing. So that's something I would be preparing for that right now.
I think that's a really important point about looking forward. But Dr. Gottlieb, I also want to look back for just a quick second about, you mentioned the importance of the screening. And I think everyone agrees now that early on in the pandemic, the US was slower to implement testing and have wide scale testing compared to other countries. And depending on who you speak to, some of the people lay the blame at the foot of the FDA as far as being the agency responsible for authorizing and allowing not just public health, but private sector companies and academic labs to be able to have the ability to create and conduct these tests. Do you think that criticism was fair?
Well, look, I've been consistent in this in terms of what I've said. I think we needed to get the commercial and the academic labs in the game much earlier. And so, at some point, and I don't know exactly when those phone calls got made and what the nature of those conversations were, but at some point in January, and certainly in February, you needed to call up LabCorp and Quest and the big academic labs and start getting them spun up. It takes time to get those tests developed and validated inside those big labs. You need to allow at least a month, maybe 6 weeks for those labs to do that. You can't just flip on a switch overnight and have those tests online and have the capacity to run them at scale. And so those labs needed to be spun up because at the end of the day, I mean, a lot of the conversation has been around the CDC test, and the CDC had challenges rolling out that tests. That test would have rolled out to the public health labs. Those labs don't have tremendous capacity. To Dr. Wen's point, we haven't built out a tremendous public health lab infrastructure in this country. I think that's going to change. I think we're going to now see that as a strategic asset that we're going to make significant investments in. But even if the CDC test had rolled out perfectly and on time, and the public health labs have stood up that test earlier, that still wouldn't have been a lot of screening capacity. That might have been enough screening capacity to do a very limited sentinel surveillance program, but it certainly wouldn't have been enough screening capacity to deal with, an epidemic of the proportion that we had. So you had to get the commercial labs in the game. You knew it was going to take time to do that, so you wanted to get them spun up as early as possible.
Okay, and in our final minutes, I just wanted to ask both of you, as we head into summer, it's going to be harder and harder, to stay at home and not want to go out and meet and interact with friends and family. What advice would you give people about the safest way to social distance? Should grandkids be allowed to see their grandparents, maybe see and not hug? What guidelines would you give to us to follow? Dr. Wen?
Yeah, so we are reopening. I think a lot of public health experts would argue that we are not ready to do so. We haven't seen the consistent decline in the number of cases that we should be. We have not met the White House's own criteria for reopening, including having the capabilities of testing, tracing, isolation. But regardless, we are reopening. And if that's the case, then in public health, we call this strategy harm reduction. That what we should do at this point is recognizing that everything that we do has risk. So how can we reduce that risk as much as possible? The virus hasn't changed, right? We don't have a vaccine. We don't have a cure. We know that the only thing that was keeping the virus at bay was reducing the transmission from person to person by physical distancing. And so any behavior that we do that involves people from different households interacting with each other necessarily has risk. But that said, I think there are things that we can do to reduce that risk. So here's my advice in general for policymakers. It would be to try to, as much as possible, follow the recommendations to reopen slowly and carefully, reopening those businesses that are essential first, to also be ready to have the stop signs, to have early warning signs and surveillance so that we know when we need to dial back and maybe reimpose some of these restrictions again. For businesses to do their part and, as much as possible, continue telecommuting. If necessary, when bringing people back, follow the best guidance of the CDC and other entities, and do things like staggered shifts and deep cleaning and keep people at physical distances, closing those common areas, not allowing many people to be packed into a conference room, or closing communal dining areas. And then for individuals, recognizing too that there's such a thing as cumulative risk, that just because we now have to go back to work, or just because we now can go to restaurants, doesn't mean that we should. And so if we do have to work, that's not an open license to now schedule play dates and schedule dinner parties and big events again. We should still use an abundance of caution in our personal lives as much as possible. And so to your point, Alice, about what are the things that individuals can be doing, I think being outside is important, getting exercise is important. Actually, being outdoors is a very safe thing to do. Compared to being in indoor crowded spaces, I would certainly recommend going outdoors, getting exercise, getting fresh air, trying to keep that physical distancing when possible. I would also recommend, when people are getting together, for example, over Memorial Day or other holidays, that they can be together in people's backyards and see each other, but again, keep a physical distance of at least 6 feet. Bring a mask, wear a mask. If you're going to be within 6 feet of each other, do not share utensils. Don't have a communal plate. I mean, I think these are the simple steps that we should be taking, while also recognizing that, again, we should not be letting down our guard at this time. We've come so far. People have made so many sacrifices in getting us to where we are. Policymakers, businesses have to do their part, but we as individuals should continue to do ours too. And so keep up our guard and use common sense at the same time.
Dr. Gottlieb?
Look, I'll just say quickly, we're not going to be able to Dr. Wen's point, we're not going to be able to eliminate all the risk here. There's going to be some persistent risk. I think those are sound points. Things done outside are safer than things done indoors in closed quarters. People just have to practice good hygiene. You have to engage with a circle of family and friends where you can have greater trust in the measures that they've been taking. And just follow good common sense guidelines, like we were doing for a period of time leading into this crisis. People were washing their hands more. They were cleaning shared surfaces. All of those things we should be mindful of and do. If everyone does those things on a wide scale, that could have a really big, profound impact on the level of spread that we're going to see. I think my concern is that as transmission breaks off and we get into the summer, and we see the virus hopefully start to recede, and we can get back to some semblance of normal lives, more of our normal lives, that we become a little bit complacent. We don't bring these practices back in the fall when we're going to be facing more risk, and we need to be doing that.
Thank you, Dr. Wen and Dr. Gottlieb, for sharing your experience and insights about how important it is that we navigate the coming months really in the right way to protect the world's public health.